No financial disclosures. We will reference the off-label use of medications. You've heard of that already. So first, our objectives today are to describe low barrier models for providing medical care to transgender people, implement practice changes to make healthcare more welcoming for transgender individuals, and describe relevant clinical concepts specific to working with transgender people. So first, a little bit about where I work. I'm from the Callen-Lorde Community Health Center. We've been around for 50 years, serving transgender people since 1969, which is an auspicious year in the US for LGBT people with the Stonewall riots. If you're not familiar, that was a riot that really brought attention to the way LGBT people were treated in the United States in 1969. So we offer all of these services, so primary care, sexual health, health outreach to teens, that's our youth program. We serve people as young as 12. We have behavioral health services, dental, a mobile medical unit, and a pharmacy on site. So, we endeavor to be as much of a one-stop shop as possible for our patients. Michael Callen was a songwriter and HIV activist, and Callen-Lorde was a writer, a poet, a breast cancer activist. That's who we get our name from. We started in 1969. We were originally volunteer staffed. The Community Health Project was our original name at the LGBT Center in New York City. And we've really been doing transgender health since we opened, like I mentioned. We were doing hormone therapy and helping people access surgery since 1969. In 1995, we had our Transgender Health and Education Project, which was one Saturday a month where people could come in for peer counseling. And our first guidelines were published in 2009. I should say our guidelines are in need of updating, and we recently adopted a series of other guidelines for our practice. So don't take them too seriously. Our last update was in 2014. All right, so what I wanted to start talking about is that, transgender people are resistant to care. I feel bad using an American idiom. A chip on the shoulder is like when someone comes in with an attitude, expecting poor care. But people really have reasons to expect getting poor care. 20% of transgender people in the United States report having to teach their doctors about transgender health. So, this would be like someone going in and saying, I think I have the flu, and the doctor saying, what is the flu? And the patient saying, I don't know, you're supposed to know that. But let me tell you about all the medications I need to reduce the course of the flu. That always just seems absurd to me. 33% of people surveyed had a bad experience with healthcare in the past year in this same survey. So there's already an expectation when coming into healthcare they're going to be treated poorly. And 2% of people report being physically assaulted by a healthcare provider while seeking care, which is just terrible. If you're going to a place where you can be vulnerable, you're supposed to be able to be vulnerable and be healthy, and you're assaulted, that's really going to make it difficult to go back to care. So this is what we're dealing with when a transgender person presents for care. Not just, a lack of expertise or social stigma, but an expectation of being treated poorly by medical providers. In order to help create an environment that signals to people that they're not going to be treated poorly, it's important to first document the correct name and pronouns and make sure that all staff know where to find those pronouns. This was, how many people here are using electronic medical records at your institution? Yeah, so for those of you, most people are not, and for those of you still using paper charts, it's so easy. You just cross out the wrong name and write in the correct name. But you can't do that if you're in an electronic system, because your billing office will say one thing, your compliance officer will say another, and where do you find a happy medium? Another thing that can make people feel welcome is having visible transgender staff. And not just in low-paid positions, but in leadership positions, making decisions about how the clinic is run. making sure that the routine day-to-day aspects of running whatever your institution is are transgender friendly. And then, these tend to be very close-knit communities, so word of mouth is really the best way to spread your reputation. Having a transgender community advisory board with people from the community to help guide your clinic. And also, you can think about that as free advertising. If you pick the right people and involve them in decision-making in the clinic, they're going to be really happy about that and happy to say that you have done that work to bring them on board. And then, we heard about this earlier, but having an online presence, a strong online presence, is really a great way to attract patients because that's where people get a lot of information. So this is our intake form at Callen-Lorde, and there's just a couple things I want to point out. We have our legal name, and then we ask for chosen name. Now, chosen name is not the best language. This should say name you want to be called. But it gives people the opportunity to say, this is what we want to be called. You're saying right off the bat that you are going to be affirming and respectful of their identity. And then down here, we have sexual orientation and gender identity. So, our patients don't even have to say anything to a staff member. They fill out paperwork when they come in privately. No one sees what they're doing. And then they can hand that in and are registered in the correct way. So having these sort of stealth ways for patients to identify themselves is really important, and not having a conversation in front of a group of people who are waiting to be seen makes it much safer for the folks who are worried about identifying in this fashion. When working, if you have a waiting room and are calling people back for one-on-one services, only using the surname, not using first names, that keeps people from being identified in a gendered way. Surnames are not gendered. And most medical records, finding ways to deal with medical records if you are on an electronic record, as I mentioned, is really important to make sure patients feel respected in an ongoing way. When we're doing physical exams, we allow patients to keep as much clothing on as possible during the physical exam. For people who work with transgender men, a lot of transgender men who haven't had chest masculinization surgery will bind or use compression garments to flatten their chest. And so I don't ever ask a patient to take off their binder. First of all, it takes 20 minutes. And second, it allows someone to have what they are doing, what makes them comfortable, to affirm themselves and keep that happening during the exam. And that goes for breast forms in transgender women, packers, or prosthetic phalluses for transgender men. We want to keep those people comfortable. I've done a series of pelvic exams on transgender men while they've kept their packers on. And so they're sitting there and holding their penis while I'm looking into their front pelvic opening with a speculum, and it's made them a lot more comfortable. They're literally touching their manhood while they're getting an exam that is traditionally for women. And then, when we're talking about genitals, we say front of genitals or front pelvic opening until a patient uses the language that makes them comfortable to refer to the body, their body, and then we echo the language that the patient uses. People have all sorts of things that they call, twig and berries, or that thing down there. So if you echo that language, that lets the patient know that you're listening to them and helps build a trusting relationship. So taking a little bit of a shift, we're going to talk about different ways hormones have been delivered in the past. And there's still places that use what's called the real-life test, which is requiring people to live in the correct gender without medical intervention for 6 to 12 months in order to access just hormones. Right? So you're asking someone to go out on the street without any tools to help make their body congruent with who they are. and just dress in a certain way, that can be really dangerous for a lot of people. You know, that can also delay what is life-saving medical treatment. And it's also confusing. You can see this kid is taking a real-life test and is pretty confused by it. Maddie mentioned informed consent as a model earlier today. Now, typically, that means not having a conversation, but reviewing a document that talks about the pros and cons of hormone therapy and what hormone therapy can and can't do. And a lot of people interpret that as needing to sign a document that says that they're like crazy enough to take these hormones that can hurt them. We don't do that with any other medication. We don't do that with oncological medications, which are completely debilitating to people. We just have a conversation. We use a medical model to inform people of the risks and benefits of taking a medication. And this is really the gold standard for hormone care. We want to be doing this in a way that we do medicine for anyone. You know, we don't start people on medications with side effects without telling them about the side effects. We don't start people on medications with risks without telling them about the risks. And we do that without making them sign a document that says that they acknowledge the risks and they're bananas enough to do it anyway. You know, this is regular medical care. And it can be more patient-centered, which, as you can see, you know, we have two doctors ignoring their patient who's right in between them. But we still want to be as patient-centered as possible and really cut down barriers to transgender related health interventions. Why do we do that? We want to increase people's ability to pass or be perceived as the correct gender. It improves people's confidence and helps people avoid transphobic violence. There's a 40% suicide attempt rate among transgender people in the United States. This is a crisis. Hormones and surgical interventions are tools that we have to make people less depressed, less anxious, and feel better in their bodies. So reducing barriers to those interventions is life-saving. You know, we have to remember hormone care and gender-related surgeries are life-saving interventions. A lot of the time people don't take that seriously or minimize, you know, what these interventions will do for people. But there is a worldwide health crisis among transgender people, and these are the tools that we have to help stop it. Lowering barriers to care means accessing higher quality of life more easily. And I forgot to finish that line and didn't catch it when I was proofreading. I apologize. So the model that I'm proposing, that I'm putting forward, is transgender primary care. What is that? That includes and is not limited to the provision of hormone therapy. Transgender people have lower rates in participation in preventive care services, including routine screening tests and, as we've heard a couple times today, PrEP. So what can we do to keep people engaged in care and coming into the office? We can get them hormones. You know, we can do all of those wonderful things that we do in primary care. We can give people vaccines. We can offer preventive screenings and routine health maintenance, as well as regular visits, and like I said, vaccinations. We see people regularly and check in about their overall health, including hormone care. We can offer sexual health and risk reduction counseling, which, you know, as we've heard, there's a very high seroprevalence rate of HIV among transgender women, and we can't do anything if they're not coming in. So if we offer hormones as a part of primary care to get people in the door, that opens all of these other opportunities up for people to get real health care. And then we also see high rates of depression and severe mental health problems among transgender people. So we can screen for those and we can address those, but only if people are coming in. All right, so I'm not going to tell you to start doing transgender primary care without giving you a few tools. These get a little bit clinical. But we have to remember that someone's identity does not define their sexual practices, right? So we have plenty of people in the United States who say that they're straight men and have anal receptive sex with people with penises. So we don't want to ask, are you gay or straight? Do you partner with men, women, or both? We want to say, what do you do? What do you like to do when you have sex? What are the gender or genders of your partner or partners? We want to have a conversation about sexual health. We don't just want to have a screening tool. We want to talk about, pardon the pun, the ins and outs of someone's behavior. And then, like we said earlier, we want to say front and back of genitals. We want to say mouth. We don't want to use medical terms for genitals, which may make us more comfortable as providers, but will cause a rift with our patients. And then, of course, we want to screen appropriately based on the risk associated with the sex acts, right? So if someone is engaging in oral and anal and they have a penis or whatever they call it, an insertive sex, we want to screen all of those sites for gonorrhea and chlamydia. Oh, and then just a quick one, if you work with a lot of transgender women who have had a neovagina, in order to screen them for gonorrhea and chlamydia, you have to do a vaginal swab. You can't take a urine test because usually there are no vaginal secretions if the person has had a penile inversion vaginoplasty. Of course, we heard about different techniques today. We can talk a little bit about those later, but we don't want to get too distracted. So we talked about PrEP a lot this morning. I just want to touch on contraception for transmasculine people. If they have a uterus and ovaries, then there is a risk for pregnancy. Testosterone is not effective as birth control. So, we want to use progestogen-based medical treatments. We don't want to be using estrogen-based contraceptives because that's going to give someone more estrogen and potentially feminize them. And we want to use non-hormonal IUDs if someone is not interested in hormonal birth control. Briefly, cervical cancer screening. Transgender men with a cervix still need to be screened for cervical cancer. There's higher rates of unsatisfactory cytology results in provider-collected specimens. There's lower rates of people coming in for an exam. And there's significant evidence that HPV self-swabs are preferred by transgender men and may increase adherence rates to cervical cancer screening. I actually have submitted a paper where we started offering cervical self-swabs for HPV to transgender men in our clinic, and we saw that our adherence rates to cervical cancer screening doubled. And they went from 20% or 25% to 50%. So that's still not a great overall screening rate when we see like most cisgender women get screening around 86, 85%. But we are still showing a big improvement. Now, the question is that it's a 71% sensitive test compared to provider-collected specimens. There's only been one validation study. What is interesting, it may be because of lower amounts of vaginal secretions in transgender men, we don't know. It's 100% sensitive in cisgender women and only 71% sensitive in transgender men. So there is need for more investigation. But our data show that if you are screening twice the number of people with a 71% sensitive test, you're still detecting more HPV than you are if you are only screening 25% of people. Just to be clear, most guidelines don't allow for HPV screening until people are 30. So this should be the second line. We should always be offering a provider-collected specimen and speculum exam first. And then once that is declined, say, well, there is this other option. The one downside to the other option is that a positive result goes right to colposcopy, which is a much more invasive exam. But lots of people would rather risk one exam and avoid that first exam. Because chances are, if they have high-risk HPV, they would have had to go for that second exam anyway. Breast cancer screening in transgender women, there are no evidence-based guidelines. There are some data that show a low incidence rate of breast cancer in transgender women, and usually those cancers are estrogen receptor negative, so they're sort of what we would typically think of as the cis male breast cancers. But we do want to be screening people over 50 after 5 to 10 years of hormone therapy. You know, I've talked to some of the pathologists that at one of the institutions where I worked, and what's really interesting is that when we biopsy transgender women's breasts, it's really the amount of time that they've been on hormones that determines the age of the breast rather than the chronological age. So if you think about it, if you're screening a 60-year-old who's been on hormones for 10 years, that's going to be breast tissue that's equivalent to what, a 22-year-old? 18-year-old? It's just interesting, but we want to, I'm going off on a tangent, I apologize. It's just interesting and not evidence-based. It's just a conversation that I had with our pathologist. Clinical breast exams are still indicated. And then when we're talking about transgender men, we want to call it chest cancer. We don't want to say the B word, because that's going to be creating a rift between us and the patient if they think that we're gendering them as female. It's important to remember that chest masculinization surgery does not necessarily remove all of the mammary tissue, but routine mammography is not appropriate for those who've had this procedure. There have been a few cases of breast cancer, mammary tissue, chest cancer, sorry, those are the three things I call it, chest cancer, among transgender men after top surgery, mostly in folks who were a little bit older and maybe had some, dysplasia in their breasts prior to chest masculinization. So it can happen. We want to examine new complaints. And I like to do just clinical chest exams on my patients who have had top surgery and document very carefully and deliberately where they have lumps or bumps that are just from surgery. So surgery will give people lymph nodes, and there's always sutures that you can feel under the skin, and if you document that, then when they come in and say, I feel something in my chest, you can look at your first note from the baseline exam and give them a little more information. All right, and I have 1 minute and 23 seconds for questions.